So we're gonna discuss ventricular septal defect, fairly common. Um, so when we say ventricular septal defect, it's an abnormal communication in the ventricular septum or opening in the ventricular septum, and there are four types. The most common is the membranous type of VSD. It's the most common type in adults. And then the muscular. So when we say membranous, it's the defect or the opening is in the membranous part of the ventricular septum. The muscular VSD, it occurs in the muscular portion, which is the thick portion of the ventricular septum. And that is the most common type in children. So, but your VSD could be a part of your endocardial cushion defect. Remember, we went over how the endocardial cushion forms. So, you know, the VSD could be a part of your AV canal defect or endocardial cushion defect. Supracrystal VSD is relatively rare, but if they give you anything with Orientals or Asian, it's supracrystal VSD is more common in Oriental population. So, what are some of the signs and symptoms of VSD? A lot of time, patients is asymptomatic. Patient don't have any symptoms uh, related to the VSD. Patient come to the echo lab for some other reason, and you pick up a VSD. Or the patient may go to the doctor's office, the doctor examine the patient and find a loud murmur, and they refer them for an echo study. So a lot of patients are asymptomatic, or the murmur is picked up. Uh, However, if they have symptoms from the VSD itself, it's usually because you have volume overload to the right side. Remember, when you have a VSD, you're going to have blood flowing from the left ventricle to the right ventricle, and you can increase your pulmonary blood flow, and they can have symptoms related to volume and pressure. Failure to thrive, that is, they're not putting on weight, they're losing weight, things like that, especially in children. The murmur for a VSD is one of the oldest systolic murmur. Remember, when we say oldest systolic, it occurs throughout all of systole. And the other murmurs that will give you an oldest systolic murmur is your mitral regurgitation and your tricuspid regurgitation. The third one is ventricular septal defect. But this murmur is heard best at the lower left sternal border, which is different from your MR murmur. Um, and you tend to get what we call a palpable thrill. That is, if you put your hand on the patient's chest, feel as if there's a ripple under your hand. So how do we make the diagnosis of ventricular septal defect? You know, of course, when you're making any diagnosis, histophysical and then test, but we're talking about echo here. So the patient come to the echo lab, how you make the assessment. So you use your two-dimensional echo, your color flow Doppler, your C doubler, and then you put everything together and you do your report. So with your two-dimensional echo or your two-dimensional images, multiple views. One of well, you're going to do your regular study, but when you do your parasternal short axis at the level of the aorta, it's going to allow you to determine, is this perimembranous or membranous VSD or a supracrystal VSD. Okay, and we'll show you how that assessment is made. So the short axis at the level of the aorta is a very important view. So it may show the defect. Also, when you do your apical 5-chamber view, you can, if it's a you can see the defect. If it's a perimembranous, you can see it just above the where you have the aortic valve, or if it's a muscular, you can also locate it. When you do, of course, you're going to do your routine echo so you can see if there is LV dilatation, RVH. Remember how to get RV thickening, okay? And then when you put your color flow Doppler in, you'll see the abnormal communication. You'll see flow across the septum, and you can locate exactly where the defect is. So again, in the short axis view, you can differentiate a membrana from supercristal. Remember, supercristal is more common in the Oriental population. Color flow jet before 12 o'clock is usually membranous. So if you see the jet, the abnormal communication before the 12 o'clock position, it is usually membranous. The color flow jet after the 12 o'clock position is usually supercristal. All right. And then when you do your C Doppler, continuous wave Doppler, you can see the flow again across the septum. It's important for you to measure the gradient. Okay, so when you do your when you measure, when you do your C Doppler across the defect, what you're actually getting is the gradient. And remember, the gradient is the pressure difference between the LV systolic pressure and the RV systolic pressure. So from that, you can actually get the RV systolic pressure, because the difference, the gradient, which is the difference between the LV systolic pressure and the RV systolic pressure. If you had the, if you subtract the gradient from the LV systolic pressure, then you get the RV systolic pressure. Remember, when you have a VSD or ASD, you're going to have increased blood flow on the right side of the heart, and that's going to increase pulmonary flow. We use the ratio of the pulmonary flow to the systemic flow, we call QPQS, to help us to determine when we should intervene surgically. Of course, you're going to use symptoms, but we use QPQS, the pulmonary flow, to the systemic flow to help us to plan surgery. You want to intervene surgically before you have what we call fixed pulmonary hypertension, before the pulmonary pressure start going up significantly, because it can, if it goes up significantly, you can get what we call a fixed defect, and patient can go on to what we call Eisenmenger complex or Eisenmenger syndrome, where the pressure in the pulmonary circuit exceeds that in the systemic circuit. And now, instead of getting a left to right shunt, you get a right to left shunt. So the problem with that is, with an ordinary VSD, you take the patient to the operating theater and you patch it, you fix it. If the patient develops the Eisenmenger complex, then you have to do a heart-lung transplant. So it's a more difficult surgery, and the patient's at tremendous risk. So you want to intervene before the patient develops significant pulmonary hypertension. All right. So in the parasternal long axis view, you can also see the turbulence. So again, you're going to do your routine study, but if you know you're looking for a VSD, you're going to put your color in. So right here we see there's turbulence, which suggests that there may be a membranous VSD. Okay, so this is the view we're talking about, short axis at the level of the aorta, and you put your color in. If you see your jet before the 12 o'clock position, it's usually a membranous. Again, remember your 12 o'clock position, just using a clock, is right here. 12 o'clock is right here. Okay, so this is before the 12 o'clock position, and this is after the 12 o'clock position. So if you see the color flow jet before the 12 o'clock position, it's usually a membranous. After the 12 o'clock position, it's a supercristal. And then with the 5-chamber view, okay, you put your color, you can see that there's a color flow jet right here, suggests that there's a communication between the left ventricle and the right ventricle. And then, each view you're gonna do your C doubler, and the C doubler will give you the gradient between the LV systolic pressure and the RV systolic pressure. And from that, you can calculate the RV systolic pressure. Remember that your LV systolic pressure is the same thing as your systolic blood pressure, as long as there is no obstruction at the left ventricular flow tract. So remember that. All right. So again, the gradient LV systolic pressure minus RV systolic pressure. Okay. LV systolic pressure is the same thing as the systolic blood pressure, as long as there's no obstruction of the left ventricular flow tract. So you just rearrange the equation and you can get the RV systolic pressure. The shunt flow, which is QPQS, okay, you should calculate it. Remember, shunt flow, this is, you're going to use P doubler. It's the stroke volume across the right ventricular flow tract. Stroke volume is 0.785 times D squared times the TVI across the right ventricular flow tract. The diameter is the diameter of the RVOT. You have to make sure that that's measured accurately. That's one of the source of error. So you have to find the RVOT, measure it accurately, and then you do the same thing for the LVOT. The stroke volume across the LVOT, 0.785 times D squared times the TVI across the LVOT. These are P doubler measurements. Okay. And we usually talk about a QPQS ratio greater than 1.5 to 2. You should intervene around that number. All right. So that is VSD in a nutshell. It's very common, so you need to know how to assess it. Okay. So we're going to move on now to anomalous pulmonary venous connection. From your normal anatomy, you know that the pulmonary veins drain into the left atrium, and we have 4 of them. We have 2 on the right, 2 on the left. We have an upper and a lower. It's important to identify these when you're doing echo, because you can have what we call anomalous pulmonary venous connection, where the pulmonary veins, instead of draining into the left atrium, drain into the right atrium or the superior vena cava or the inferior vena cava. Okay, and that can cause some problem. You can have total anomalous pulmonary venous connection, where all 4 pulmonary veins drain into the right atrium or the superior vena cava or inferior vena cava. So this is a problem, because this you have to do surgical correction, because all your oxygenated blood is now going to be on the right side, which is not your normal anatomy. Or more commonly, you can have partial anomalous pulmonary venous connections. For total anomalous pulmonary venous connection, all 4 pulmonary veins connect to the systemic circulation. Okay. For these babies to survive, you need a patent form ovale or atrial septal defect, because you have to get oxygenated blood on the left side. Okay. So if the pulmonary veins are draining into the right side, to get the oxygenated blood to the left side, you need a patent foramen ovale or atrial septal defect. 50% of these anomalous pulmonary venous connection total the pulmonary veins drain into the innominate vein or the superior vena cava. So it, can drain anywhere on the right side. So either in the innominate vein or the superior vena cava. Patients who have total anomalous pulmonary venous connection tend to have some cardiac defect in about 20% of cases. Um, the pulmonary veins can also drain into the coronary sinus or the right atrium. And you can get what we call the infradiaphragmatic, where the pulmonary veins drain into the portal or the hepatic veins. And you can get a mix where drain, superior vena cava draining the coronary sinus or draining the hepatic. But you can have any combination. It can drain anywhere on the right side of the heart. Okay. More common though is the partial anomalous pulmonary venous connection, where just some of the pulmonary veins connect to the systemic circulation, not all. And more common is either in the superior vena cava or the right atrium. You might see this syndrome from time to time, scimitar syndrome, where one or more of the pulmonary veins drain into the inferior vena cava. Okay? Or it might just drain into the coronary sinus. Not all four drain into the right side, just some of the pulmonary veins. So, how do you use echo to assist in this diagnosis? When you're doing your echo, you should identify all four pulmonary veins, because the patient is not going to come to you and say, well, I have anomalous pulmonary venous connection. So you have to identify that all four pulmonary veins drain into the left atrium. So with your apical fourth chamber, you can see the right and the left lower pulmonary veins. And in the subcostal fourth chamber view, you can see the right upper pulmonary veins. And then in the parasternal short axis, you can see the left upper pulmonary vein. If you're still not sure that you're seeing all four pulmonary veins draining into the left side, then you do a transesophageal echo, okay, to identify them. So again, with the apical 4 or 5 chamber view, you can see with apical 4, you can see the right and left lower. Okay, so this would be the right, and this would be the left. Okay, remember when you do your pulmonary vein flow, you use any one of these. So it's a right and left. Okay, and then with the subcostal view, you identify the others. Okay, right, upper. All right, so that is your pulmonary veins. Remember, you have to search for them. It can be a problem. Partial is more common than total. Now we're going to look at PDA, patent ductus arteriosus. Remember when in utero, in fetal life, you have what we call a PDA, patent ductus arteriosus. Well, you have a ductus arteriosus, and it allows blood flow into the pulmonary circuit, because the lungs in the baby is not fully developed. Okay, the lungs in the baby is not fully developed. So, the pulmonary circulation, some of the pulmonary circulation come from the ductus arteriosus. But when the baby is born, it usually gets what we call a physiologic closure. So it closes off. If it does not close off, then it can pose a problem, because you're going to have increased blood flow from your aorta across the ductus arteriosus into the pulmonary trunk. You're going to get increased blood flow in the pulmonary circuit. And remember, increased blood flow in the pulmonary circuit is going to give you pulmonary hypertension and problems related to that. Okay? Again, so with your PDA, it is failure of closure of the ductus arteriosus after birth. It's supposed to close. And then now oxygenated blood is going to flow from the aorta to the pulmonary artery. Remember that the pressure in the aorta is greater than the pressure in the pulmonary circuit. So you're going to have blood flow from the aorta into the pulmonary artery. You're going to get increased blood flow and then the problems related to that. So the signs and symptoms of a PDA, tachycardia as a compensatory mechanism, increased heart rate, shortness of breath, and when you listen with your stethoscope, you get what we call a continuous murmur. It's a continuous murmur because you're going to get the murmur in diastole and systole. So both systole and diastole, you're going to get the murmur. So it's not a systolic murmur. It's not a diastolic murmur. It's a continuous murmur because you're going to have blood flow across the PDA in systole and in diastole. Okay. You get cardiomegaly. Usually with a PDA, you get left-sided enlargement, okay, which is different from like your ASD, where you get a right-sided enlargement. With VSD and a PDA, you get left-sided enlargement. So you can also get a bounding pulse, widened pulse pressure, which is the difference between your systolic blood pressure and your diastolic blood pressure. Okay, so you get a widened pulse pressure. The pulse pressure is the difference between the systolic and the diastolic pressure. Poor growth, failure to thrive, differential cyanosis, and heart failure. So with your two-dimensional echo and Doppler, in the parasternal short axis view, at the level of the pulmonary bifurcation, you can see flow going from the aorta into the pulmonary trunk. Okay, remember it's a communication between the aorta, usually at where you have the left subclavian artery. Okay, so you'll see flow from the aorta into the pulmonary trunk. So you can, with a high left parasternal long axis view of the pulmonary artery, you can, what we call a ductal view, you can see the flow or the communication. Remember, when you do your short axis at the level of the aorta, and if you concentrate a little bit more on the pulmonary trunk, we talk about two pants leg, or two pants leg, which you have the main pulmonary trunk, which divides to give you a right main pulmonary artery and a left pulmonary artery. If you see a third leg, then that's usually a PDA. Okay, so high left parasternal long axis view of the pulmonary artery, your ductal view. If you do your suprasternal notch, remember we say the PDA is a communication between the aorta and the pulmonary trunk. With your suprasternal notch view, you can actually see the left subclavian artery, and then you can see an abnormal communication from the descending aorta right at that level going into the pulmonary trunk. So suprasternal notch view is a good view. You're gonna do your color flow because that's gonna show you the flow. Continuous wave Doppler because you want to measure gradients, and again, PDA is gonna give you LV and LA dilatation. Okay, just like your VSD. All right, so again, this is a cartoon showing the PDA. So this is your aorta, coming out of the heart, the ascending aorta, the arch, descending aorta. So your left subclavian artery is right there. And then this is your left common carotid. This is innominate. So the PDA is a communication right at the level of the left subclavian between the aorta and the pulmonary trunk. So you're going to get flow going from your aorta into the pulmonary trunk. You get a continuous murmur because the flow is going to be in systole and diastole. That is because in systole, the pressure in the aorta is greater than the pressure in the pulmonary circuit. In diastole, the pressure is still greater. So you're going to get flow from the aorta into the pulmonary trunk in systole and diastole. So you get what we call a continuous murmur. So it's not really a systolic murmur or a diastolic murmur. It's a continuous murmur occurring both. So again, if you see your third pants leg, it's supposed to be 2 because the pulmonary trunk divides to give you a right and a left. So if you see 3, okay, so you're going to get a lot of turbulence, a lot of flow into the pulmonary trunk. And that is why when you're doing your assessment of flow across the right ventricular flow tract, you usually start above the pulmonary valve and you work your way down gradually to see if there's increased gradient. Okay, so this is color flow from the PDA to the pulmonary artery. Okay, so that is important. So PDA, patent ductus arteriosus, it's one of the things that will give rise to pulmonary hypertension. You get LV dilatation, left atrial dilatation, continuous murmur. So you know how to assess your PDA. The next thing is the coarctation of the aorta. Now, coarctation of the aorta, or coarctation of anything, is a narrowing. It narrows. So when we say coarctation of the aorta narrows in the region where the ductus arteriosus inserts. The ductus arteriosus usually inserts close to where, just as I showed you, where the left subclavian artery comes off the aorta, the descending aorta. Okay, so just at that level, that is where you usually get coarctation. And when you have coarctation, we usually talk about a preductal, a ductal, and a postductal. All that means is if the coarctation is at the level of the ductus or right at the level of the left subclavian, or is it below? If it's below, then it's postductal. If it's above, then it's preductal. And when we say ductal, is just the ductus arteriosus, which is a fetal a circulatory pattern. But the ductus is usually right at the left subclavian. So if you use the left subclavian, you're fine. Again, remember that coarctation of the aorta is common in Turner syndrome. Turner syndrome, okay? It is twice as common in boys as it is in girls. And remember, you need to know how to identify Turner syndrome: short stature, web neck, mental impairment, okay? And the other thing that goes with Turner's a bicuspid aortic valve. So, that's fair game in the exam. All right. So, again, we talk about preductal. So this is a narrowing, which is just before the ductus arteriosus. Remember, the ductus arteriosus is usually at the same level of the left subclavian. So we have a preductal. We have a ductal, which is narrowing at the insertion of the ductus arteriosus, and then postductal, which is narrowing just distal, just below the ductus arteriosus insertion. So usually it's not as dramatic as this. So the aorta, you have the ascending aorta, the arch, and then the descending aorta. It's a narrowing. Usually not as dramatic as this. Sometimes it's just a mild narrowing, okay? But this sort of tell you what it is. So your left subclavian will be, say, right here. So this would be like a postductal. If the left subclavian was right there, then to be a ductal. So just imagine the aorta comes up and then it narrows. At the point of narrowing, you're going to get increased velocity. And with the increase in velocity, you can calculate the increased gradient and you can determine the degree of obstruction right there. Okay? So what are some of the signs and symptoms of coarctation of the aorta? Mild cases may have no signs or symptoms until later in life. So again, come to the echo lab, routine study, pick it up. Okay? They may have other cardiac defects, such as bicuspid aortic valve. Remember we said that Turners tend to have bicuspid aortic valve as well. They may have ventricular septal defect, mitral valve abnormality as well. And if the obstruction is significant, they have shortness of breath. But one of the classic feature of coarctation, if it's significant, is the increased blood pressure in the upper extremity. So you have an obstruction in the aorta, the descending aorta. So blood cannot get down into the descending aorta. So the pressure above the obstruction is going to be increased. So when you do the blood pressure in the upper extremities, it's going to be high. Okay? And sometimes you can see veins popping out of the patient's chest and neck. There's another thing we call radiofemoral delay. Because you have an obstruction in the descending aorta, you're not getting enough blood into the descending aorta. So you're going to have a weak pulse in the lower extremity. So when you do your femoral pulse, the femoral pulse are going to be weak. So you check them, they're going to be weak. When you check the pulse in the upper extremity, they're bounding. Pulse is great. So we talk about a radial femoral delay. Because of the obstruction, there's going to be a delay in the femoral pulse as compared to the radial pulse. Okay? Just because of the obstruction. Again, poor appetite, if it's a significant obstruction, failure to thrive, especially in kids. If it's significant, they're not going to grow appropriately. If it's significant, dizziness, syncope can pass out and it can get chest pain. Okay, fatigue, headaches because of the increased pressure, hypertension in the arms, so high blood pressure in the arms, low pressure in the legs. Okay, and then the radiofemoral delay because of the obstruction in the descending aorta. The blood flow in the descending aorta is going to be low and delayed. So how do you use your echo and Doppler to make this assessment? Okay, so again, you have an obstruction, so you're going to get eye velocity, eye gradient. One of the views, you can use your high left parasternal view, but of course the suprasternal notch view is where the money is, because that's where you can see the obstruction. And then when you do your Doppler assessment and your color and your C-doubler, you can just pick it up. The classic feature is the sawtooth pattern in your continuous wave Doppler. So you have to remember what your normal C-doubler or P-doubler across the descending aorta looks like. So you have to know what the normal P-doubler looks like or C-doubler looks like across the descending aorta. So if you get a sawtooth pattern, there's an obstruction, so coarctation, and the color flow will show alicin. So you need to, in your routine study, you need to know what the normal looks like. So when you get something abnormal, it stands out readily. So again, your suprasternal notch view, and you're accustomed to put your cursor, your sample volume in the descending aorta, and this is what you're supposed to get. ECG is on top. In systole, you get a nice waveform, usually about 1 meter per second. It goes straight to the baseline, and that's it. So this is what the normal uh, uh, Doppler flow across the descending aorta looks like, as opposed to this, where suprasternal notch view. This is your ascending aorta, the arch, descending aorta. Again, this would be your left subclavian. This would be your left common carotid, and they innominate someplace over there. So your coarctation is usually at the level of the left subclavian. It can be below it, it can be at the left subclavian or above it. But when you put your Doppler there and you get something like this, in diastole, it doesn't go to the baseline. Okay, so it has a sawtooth pattern. And then when you look at the gradient, it's the velocity, the peak velocity, it's now more than 1 meter per second, telling you that there's obstruction. Okay, so this is classic, okay, sawtooth pattern. Okay, you have a diastolic velocity where in the normal Doppler across the descending aorta, it goes straight to the baseline. Now we have a diastolic velocity, and then the peak systolic velocity is increased. This is a sawtooth pattern, which is classic for aorta coarctation of the aorta. All right. So again, your suprasternal notch view. This is the ascending aorta, the aortic arch, and the descending aorta. This is your right pulmonary artery, and this is your brachiocephalic vein. So remember again, your left subclavian, common carotid, innominate. Okay, so this is where you usually get your coarctation. Remember the association with Turner's bicuspid aortic valve, increased blood pressure in the upper extremity, decreased blood pressure in the lower extremities, radiofemoral delay. All those things are tip-off, sawtooth pattern. Okay, so that we're going to stop here.